As usual, welcome everyone. As a reminder, just some housekeeping items. If you have any questions, feel free to throw those down in the chat. We'll try to either answer them live or as we go, we'll answer them via the chat. The recording will be made available at recap.com within 24 to 48 hours afterwards. We get a lot of questions about that. So if you miss it today or if you have to sign off early, you can access that. And then I guess as always, we want to remind everyone that we are an investment firm regulated by the SEC. So nothing we say today should be taken as investment advice. So with that, I'll turn it over to you, Peter.
Yeah, I would say nothing should be taken as investment advice except at the societal level, because we're going to be making a call for some significant investment. So yeah, RA Capital is a biotech firm. We're really data driven, and the future for us is always a set of probabilities, right? And what we're going to share with you is a story of how we went into January expecting that the most probable outcome was that the first generation of vaccines would manage this pandemic, and that in the future, sure, there could be strains, but there's too much talk of strains, that strains wouldn't end up being that big of a deal, and we'd be able to adapt the vaccines down the road sometime. But we honestly did not think that we would be spending 2021 or the very beginning of it thinking about strains and particular mutations. We thought that was sort of overkill by people that saw the worst in everything. So our probabilities told us things would be fine, and our probabilities were rooted in most recently in great data from companies that were developing the mRNA vaccines, showing a very high rate of preventing symptomatic infection. It reassured us that these initial vaccines would end the pandemic. Right? You guys see us, you see me progressing through the slides, I trust. Yeah.
Yes, we do.
And this wasn't a surprise to us, because earlier in 2020, we saw all these neutralizing antibody titers, these levels of antibodies that the vaccines were generating. And the red bars tell you what the levels of antibody can be in people who have recovered from COVID. And what you could see was that the vaccines were getting you, to those levels or above, right? And so it felt like, okay, these vaccines are going to end up, giving us the kind of immunity you would expect from somebody who's recovered from COVID, or better, actually. People said, all right, well, maybe this wasn't surprising, but what about new strains, right? And to understand why we felt that new strains wouldn't pose that big of a challenge to people who have been immunized, you got to understand what it is that antibodies do, right? And we've shown a diagram like this before. If you think of this as being the cell, here's the ACE2 receptor, and this is the virus, and here's its spike protein, and where the two meet, that's how the virus starts its entry process into the cell. And what antibodies do is they learn to recognize all these different parts of the spike protein, and they glom onto it. And certainly the antibodies that are here in the top region are most important. They're what help prevent the spike protein from interacting with the ACE2 receptor, right? And so, if you get a mutation, all right, so this antibody can't bind there anymore because the protein structure is different. It's strange looking, right? But you still got all these other antibodies around, right? And so we thought that ultimately there would be enough of these other antibodies that you wouldn't see a notable decrease in immunity. And so what changed? And the answer is new data, right? And we're always having to adjust to new data. Our companies are generating data left and right and adjusting our probabilities. And in this case, this was a pretty significant change to our assumptions. So the new data at first emerged from Novavax. And the very top line data didn't really look necessarily all that odd. They reported 89.3% reduction in symptomatic infection, and that's less than a 95%. But these are small trials. You think like, okay, maybe that's chance. But as you read the press release, you start to think like, maybe something is going on. So it's a bit weird that it's lower, but it could just be chance. But what they did was they sequenced the viruses that people had and determined that, and this was data that emerged out of their UK study, that in fact, they had basically done a trial, two trials in parallel. One trial was how well the vaccine worked, protecting against, well, I'm jumping ahead here, against the original strain. And then they had some data on the new strain that was going around. Now, remember, we expected Novavax to have the highest neutralizing antibody levels. And so we expected them to be more up here at the 95%. So that's why this slight reduction was a little weird. But it turned out that when they showed us the data in the press release for the protecting against infection of the original strain, sure enough, their vaccine was as good as all these others, right? When you're up that high, it's kind of hard to tell the difference between one vaccine and another. They're just great. But the UK strain, this new strain, it was a little worse. And you think about that and you say, is that just small numbers? Maybe this is just a chance fluctuation, but they actually had more data than that. They were also running a study in South Africa where you had this other strain, the South African strain that had more mutations. And this one, this strain seemed to be able to infect more people despite being vaccinated. So the vaccine was less effective in preventing infection with this strain. There was another bit of data that we had, which was that when they looked at people who had enrolled in their study and had antibodies to the original virus because they had already recovered from infection, they saw that those people had the same rate of being infected by the new South African strain as people who had never been infected before, had never recovered. So pre-existing immunity from infection, so recovering from the original strain, did not protect you against infection with the South African strain. And it was equivalent levels of moderate to severe disease in those two patient populations. So recovering from the original strain of the virus didn't even sort of help keep whatever subsequent disease you got from the new strain from being just as serious. So that was pretty discouraging too. And then essentially the next day, we got data from J&J, which pretty much confirmed that this wasn't some weird thing specific to Novavax. They saw overall 66% protective rate, but when they split it out by the original strain versus the South African strain, because they also had sites in South Africa, they saw that you saw the similar drop in effectiveness of the vaccine against the South African strain. Now, if we look back way back when, we got some data from AstraZeneca that suggested that their adenoviral vaccine was less protective than the mRNA vaccines. So going all the way back here, AstraZeneca had the lowest antibody titers of any. Looking at these blue bars, they were lower than all the others. So we would have expected AstraZeneca to be weaker. We just thought like maybe it's strong enough, right? And so here we have AstraZeneca's data, being weaker on protecting against infection, and J&J comes in with their adenoviral vector, same idea as AstraZeneca, and show pretty much the same lower levels of protection against the original strain. So this would be the closest thing to a head-to-head trial, head-to-head apples-to-apples comparison of J&J and AstraZeneca data, because back when AstraZeneca did this trial, you didn't have a South African strain circulating. And so we can imagine that if Novavax's vaccine, on the original strain is as good as the mRNAs, but is much weaker in the face of the South African strain, if you were to run these mRNA vaccines now in South Africa or anywhere where that South African strain is spreading, it's a bit of a misnomer at this point, it's a global strain. We would expect it to be lower. And similarly, we would expect that if AstraZeneca were to run its trials, it would similarly be weaker, maybe like J&J's, at protecting against the spread of the South African virus. So, when you now look at how these antibodies work, what you realize is a mutation like this matters, right? And we can no longer assume that we've got plenty of coverage from all these other surrounding antibodies. that was kind of the surprise for us. We're like, wow, uh, uh, you know, these one-off mutations are gonna matter, right? It's a lot easier for this virus to circumvent immunity than we thought. And so we thought all these other antibodies would be enough. Uh, Now the question is, were we wrong? And in a sense, yes, we were wrong, as I just showed you. But in another sense, no, we kind of weren't. Because when you think about, what we really want to protect people against, it's severe disease. You get a sore throat, you get some fatigue, fine. You feel like you've got a severe cold, maybe you even feel like you've got the flu. We live with those things. It doesn't shut the world down. I shouldn't, sort of brush it aside too much. There are older people who die, 20 to 60,000 Americans die every year from complications associated with the flu. These tend to be older people with respiratory problems, right? So, you know, COVID looks like it could be that for people who are vaccinated. Um, they'll get mild to moderate COVID, but they won't really get severe COVID. And to be clear, even here in the J&J trial, which showed an 85% reduction in the incidence of severe COVID, severe does not mean you go to the hospital. I talked to the folks at J&J and they said, like, the vast majority of the people who did get severe COVID after being vaccinated still didn't end up going to the hospital, right? So these are really going to protect against hospitalization. However, these trials, for the most part, when you think about it, tended to skew towards still the healthier people in the population. They say that they enrolled people with comorbidities, but the truth is that the sickest people tend not to be the ones that enroll in trials, right? And so as you think about how few 80, 90-year-olds there are in these trials, and yet the fact that there's about 20 million Americans that are 80 years old and above, it's not hard to imagine that, if even a small fraction, of them are left exposed and vulnerable, that you could still see quite a few, tens of thousands, hundreds of thousands of much older people getting infected by virus that is hop, skipping, and jumping through everybody in the country that's vaccinated, barely feels COVID, but the virus is circulating among all those people and finding the vulnerable in whom the vaccines, did not, drive a strong immune response, right? And if we're talking new strains that can circulate, then as a new strain evolves, like the South African strain, it's going to be able to infect a bunch of vaccinated people and find the weakest among us, right? So how does that work? There's a process called immune selection that's worth talking about, which has only just started to kick in, and we think may be a reason why we're seeing the emergence of some of these mutations that allow the virus to get around immunity. So imagine that you've got all these people where you've got half the population's vaccinated and half is not vaccinated. And the original strain, let's say, is infecting all these people here that are not vaccinated. And all of a sudden you've got a mutation. Like in this one infected person, you've got this mutant virus, right? And the mutation can circumvent immunity to the original strain. So these people here are recovered people who have immunity against the original virus. But these mutations allow the virus to infect these people, right? And so this is the main concept here. Mutations that circumvent immunity to the original strain are not complex. It just takes one change in the code of the virus to create the E484K mutation, changing glutamic acid to a lysine, I believe, right? And that one mutation seems to matter, right? And so this virus now is rewarded with more hosts. What do I mean by that? Who are the hosts that it can infect? Well, it can now infect some of these people that, if I flip back and forth, you'll see these people up here are recovered from the original strain, but the new virus says, no problem, I can still infect you, right? So it can replicate among them, whereas the original strain can't. It can only replicate in other non-vaccinated people, right? And at the same time, this new virus can infect all these people that are vaccinated. it does not have to compete with the original virus for all these people, right? So the moment the virus stumbles upon a mutation that gives it the ability to infect previously recovered people and everybody who's been vaccinated against the original strain, it's rewarded with a ton more people that it can infect. And the original strain is sort of left behind to pick its way through the unvaccinated population, right? And so this is immune selection, a reward for any virus that stumbles upon a beneficial mutation like this. And as you have more people who are recovered from the original strain, and as you get the initial first generation vaccines rolled out, you're going to have this bigger and bigger reward, this growing jackpot for any virus that picks up new mutations that give it these new tricks. So what did we learn? It's a lot easier for the virus to evolve around immunity than we thought, right? Just these first few mutations that have emerged seem to give the virus these new powers. So we have to keep evolving vaccines to keep up with the virus, right? We knew we might have to do that. We knew that these vaccine modalities could do that. We're just discovering we have to do that quickly, soon, this year. I did not think we'd be spending 2021 talking about the next generation of vaccines, but that's what we are going to talk about. And we're going to talk about how some vaccines are better suited for keeping up with the virus than others. So here's the bottom line. We like to put it at the top. Conventional protein adjuvanted vaccines can be expanded to cover more strains without worsening tolerability, right? So conventional vaccines, Novavax is a conventional vaccine. All the flu vaccines that we get, you can think of as being fairly conventional. They consist of a protein antigen, that shows the immune system what the virus looks like and what to attack, and an adjuvant, which is an immune stimulant, right? Now, the alternative would be an mRNA. That's a newer type of vaccine. And you can encode the sequence into an mRNA, you inject it in a person, and the person's own cells will make the spike protein and show it to the immune system. And the cool thing about mRNA is that it's self-adjuvanting. So it both shows the immune system what it needs to attack. So antigens are what show the immune system what to protect against. And it activates the immune system, right? And says, pay attention to this. So the mRNA does it all. In the case of a conventional vaccine, you typically need to introduce the protein that you want the immune system to pay attention to, and you have to add an adjuvant to get the immune system to pay attention to what you just injected, right? So the downside with adjuvants is that they can cause pain and fever. They're revving up your immune system. And so that comes at some cost, tolerability, cost, but not really serious adverse events. Certainly not if you don't overdo it, just uncomfortable for a day or two. And we've been reading about that in the press and we see it in the clinical data. But here's a problem. When you need to cover a second strain, in the case of mRNA, you just create a new mRNA with a new code for the second strain's protein, right? So now you've got these two mRNAs, one covering strain 1, one covering strain 2. In the case of a regular conventional vaccine, you simply add more of the protein, but you keep the same amount of adjuvant, right? So that means that mRNA gets more painful as you expand the number of mRNAs and you increase the amount of mRNAs in order to teach the immune system to protect you against more strains, whereas the pain level for a conventional vaccine stays the same. Expand that to 3, and now you've got yourself a real challenge, right? So you would need to reduce how much you give of each mRNA as you expand the number of mRNAs you give, right? And that means that you may not be giving enough of a given mRNA. You may not be drawing enough attention to a particular new strain. So that represents one of the problems with relying on mRNA technology to help us keep up with the virus. I don't talk about here adenoviral vaccines. Their fundamental problem is that they come packaged in an adenoviral vector, and the immune system develops antibodies against the adenoviral vector as well as the COVID spike protein that adenovirus encodes. So when you try to give that adenoviral vector again, but this time with a new code for a new strain, your immune system says, oh, wait, I've seen this Trojan horse before. and it rejects the Trojan horse. That's what you should think of an adenovirus as being, like a Trojan horse delivering instructions. So do we have evidence, by the way, that these mRNAs are hard to tolerate as you increase the amount of mRNA you give and the number of mRNAs that you combine? And the answer is kind of yeah. So we looked at a bunch of Moderna's programs because they have a very extensive pipeline of vaccines. And this is a little bit, too hard to see the fine print, but we basically color coded the tolerability data. You got your local pain, swelling, fever, headache, fatigue, muscle pain, chills, joint pain, and green basically represents what the current threshold is of each of these adverse events occurring with the current vaccines, which is to say, green is not all that comfortable. These mRNA vaccines are already more uncomfortable than any other commercially available vaccine in the history of vaccines. But the very fact that millions and millions of people are getting them, coming back for the second dose, and here we've got data for the first dose, and this is the data for the second dose, so the second dose is more painful. The fact that they keep coming back is testament to the fact that they're tolerable enough, right? If you had a choice between this and a less painful vaccine, sure, you'd take a less painful one, but they're tolerable enough. But as you go to more mRNA, that where you have more mRNAs, like more antigens that you're covering, what you see is that you're getting to levels of tolerability that are worse than what we have now. So here, yellow would be comparable to the tolerability of 250 micrograms of mRNA. The current doses are 100, so that's less tolerable. And then the red here, as you get up to about 300 micrograms, is worse than that. So we're going to have this on our updated map. People can study it in more depth. But the bottom line is, the mRNA companies need to work on how they can reduce the pain and the amount of immune stimulation that their mRNAs are covering, so that they can give more mRNA and cover more antigens without driving the what's called reactogenicity of their vaccine through the roof. If they can't do that, if they can't do that soon, it just means we're going to be relying on conventional vaccines. The kinds of things that typically vaccinate us against flu and a lot of other infections. So bottom line, we need to stay ahead of this virus, which means expanding vaccines to cover more strains and boosting periodically. It means certainly, I should back up, it means continuing to monitor for the evolution of new strains, so sequencing of the strains that are circulating around the world. Conventional protein-based adjuvanted vaccines seem best suited for staying ahead of this virus so that you can increase the number of strains that each shot covers. Moderna and Novavax have said that they're moving ahead with creating bivalent vaccines, meaning two antigens, basically. They'll cover two strains. We need to invest in expanding manufacturing of these conventional vaccines and get to the point where we can produce hopefully billions of doses very quickly, right? If we don't do these things, then new strains are likely to circulate among vaccinated people as well as those that have recovered from infection and find their way to the most vulnerable among us and do some harm, right? So I would make the case that one of the differences that you hear about mRNA and protein vaccines is mRNA can be changed on a dime. You can get a new sequence and you can make a new mRNA vaccine very quickly, within weeks. And the truth is, you can do that with the protein-based vaccines too. But maybe like instead of 2-3 week response time, maybe it's like a 2-month response time. Essentially, for Novavax's process, they get a sequence, they have to grow up a new batch of baculovirus that encodes that sequence, and then they have to infect some insect cells with that baculovirus, and it takes them about a week to grow up a batch of protein. They got to purify it. So it's actually a pretty rapid process. and they say that they can make about 150 million doses per month. And if you're going to be making a basically a two-strain vaccine, I'm not sure, but I think that means that the current manufacturing, if it had to be split between the original strain and the new strain, you're talking really about 75 million doses per month of bivalent vaccine. So, it would take you a long time to manufacture, enough vaccine to vaccinate a few billion people, right? So who cares if, it takes you a month longer than mRNA to, pivot your manufacturing, if you're going to be spending a couple years manufacturing enough vaccine to get to everybody. So the way to shorten your time to vaccinating a critical mass of people is actually to invest in a lot more manufacturing, so that you can be producing, I don't know, let's just say 1 billion doses per month. If you could do that, then you can take an extra month longer than others maybe to pivot to a new strain, but then you generate enough to vaccinate the world on the scale of a few months, and that matters a lot more. So I think an interesting question will be, what's easier to scale, mRNA production or conventional vaccine protein-based production? I suspect it's probably protein-based, but that'll be something to look into. So I think that the advantage lies here with conventional vaccines for the long run, and better tolerated, and are fast enough, and I think manufacturing is easier to scale. So I'll stop there. We've used up almost half our time, and now let's do the usual Q&A and banter that we normally enjoy. So monologue done.
So we have a bunch of Q&A coming in from our audience, and I definitely encourage, if you have any questions, to please submit them and we'll get to them. And maybe, excuse me, I could start off with just like a topic that I thought about when you were talking about, Peter, how for Novavax's data, for when they were looking in their placebo group, and they looked at the rate of infection between people who were seropositive and then seronegative at baseline, there wasn't a difference. And so that would suggest that if you got a previous infection of COVID, you were not protected against the South African strain. And so a term that we've heard, just thrown out more recently is original antigenic sin. And so I thought this would be a good opportunity to bring that up and talk about it and just prime the audience for what that might be. So just curious to hear your thoughts on that.
Antigenic sin. That's such a cool term. And I expect we might be talking about it more, but here's the basic idea. If you think about a vaccine, right? It's the first time you put a vaccine into a person, the immune system pays attention to all parts of that protein. And I should probably share my screen again just to pull this up one more time. But let me see here. I already can't remember where the slide deck is. Well, anyway, I will. Oh, here it is. Okay, so you're gonna see this protein. All right. Can you guys see this screen? Is that showing up? Are you seeing the protein?
We're seeing a protein. Yeah.
All right, cool. So you show it this protein, and the immune system says, wow, I haven't seen anything like this before. I'm going to learn about every single nook and cranny and learn to develop an antibody against all of them, right? And so it does that. And then later, when you have this mutated protein, and this antibody doesn't bind anymore, but it turns out like it's a pretty important one to keep you protected. And so you want to give the mutated, the South African strain of the protein to the immune system. The immune system notices so much in common with what it saw the first time that it can sort of rush the judgment and be like, oh, you want more of all this stuff that I'm good at, and it gives you more of all these other antibodies that already bind to this. But it doesn't go out of its way to develop a new antibody that would recognize this new mutated spot. And so antigenic sin basically means that you are condemned to only protect yourself against the first version of of whatever virus you've seen. Now, it's a bit overblown. Is antigenic sin a problem? Rarely. We still clearly, respond to new flu vaccines each season, and they help to shift our immunity over to new versions of the flu proteins. And so odds are it's not an issue, right? But people do fear that, if it just takes one subtle little change of the virus in order to get around our immunity, then when you try to update vaccines, you're going to have a hard time focusing the virus, the immune system, in on that one changed portion of the spike protein. So we're going to find out. I don't think it's going to be an issue, but it's the sort of antidote to antigenic sin, by the way, is to say you're better off giving an initial vaccine to somebody who's never been vaccinated that's as broad as possible, right? So the argument would be that you're better off giving somebody who hasn't been vaccinated a bivalent vaccine that shows them both the original antigen, the original strain's antigen, and the South African strain's antigen at the same time, rather than give that person one shot of one and then another shot of the other, right? So you'll get a broader response. So, there's a lot of cool immunology science here. We may learn more about antigenic sin as we see, how these vaccines work in different people. But I think it's way premature to be saying that we're going to be stuck amplifying only the original immune response and not developing antibodies against, the mutated regions. I hope that was clear. What else have we got? Wow, 32 questions. We got a lot to cover.
We've got quite a few questions around using RNA as boosters. I think people get the message around packing multiple strains into one mRNA vaccine, but a lot of people asking why you can't just give single strains as boosters. So what are sort of the logistical?
It's possible that you might, but again, you're going to want to protect people against the original strain as well, because the original strain, there's a risk that your antibody levels may wane over time, and the original strain is going to be able to now infect people again. So we don't really expect the strains to die out, right? The original strain will still circulate. The UK strain will still circulate in pockets, and you may get a diversity of different strains going around. And so when you vaccinate people, it's kind of like whack-a-mole, right? Rather than whack them sequentially, if you can basically get more hands involved and like cover all those, little, portals or holes in the game, then you can keep, you can sort of win the game. So I think that some groups are going to be forced to do it one at a time. They're not going to be able to combine. Some people are naturally just going to get the boosters rather than get a new bivalent vaccine. So we're going to learn a lot more about which approach is better. But the safest approach, as you can see from what Novavax announced, is to just create a bivalent vaccine. Certainly, because we still got tons of people to vaccinate for the first time. All right, what else have we got?
I can throw one out.
Mask wearing. I see a comment about mask wearing. Yes. So what this means now, if moderate COVID is annoying, right? You might want to think about wearing a mask in crowded places. You got one more threat. I think all of us have just enjoyed a period of time where we have fewer colds. There's less of all kinds of infections. There's less RSV, less flu, right? And if you're going on a vacation somewhere or whatever, and you're walking through an airport, I think we've all just been sensitized to how much stuff is out there that you can get. Is it such a bad idea to wear a mask, to keep wearing a mask? Well, I think that these new strains, to the extent that they're, going to be circumventing immunity, make us realize that there's plenty to be gained by continuing to wear masks, at least in crowded places, right? So I hope we come out of this still wearing masks certainly at least in crowded places, and that we're not shaking hands. I think that's a pretty antiquated tradition, and maybe we can do away with it and help keep the spread transmission down as much as possible. All right, what else should we jump to?
I saw a pretty interesting question. It was relating to the protein-based approach. So really, like, the fundamental advantage there is that you can stack multiple antigens in one shot. And the question said, basically, when you put multiple antigens in a protein-based vaccine, but you keep the adjuvant dose the same, is that going to reduce the immune response that you get to each antigen, or are you going to get an equal response to all of them?
Yeah, so the thing actually that the FDA wants to see when you when you combine vaccines, is they want to confirm that you don't get interference between the antigens. I don't think that you overcome interference. Basically, where you get a high titer of neutralizing antibodies to antigen number 1, and if you gave antigen number 2 on its own, you'd get a high neutralizing titer, but then when you give them together, you get less, right? So we haven't actually seen that for like Novavax's flu program. You don't see that for a lot of protein adjuvanted vaccines, but you do have to confirm it because it does occasionally happen. So you need to confirm that that's not going to be a risk. To my knowledge, there's nothing out there that suggests that you would need to increase the amount of adjuvant. You've basically decoupled how much alerting you're doing of the immune system to, come, hey, look at this, from telling the immune system what to look at, right? In the case of mRNA, those things are coupled. In the case of protein adjuvanted vaccines, they're decoupled and you can dial in the right amount.
So we definitely have a lot of questions, additional questions. I saw 2 other interesting topics to bring up. First, I'm just going to quickly clarify because I've seen a couple of people ask, is it really fair to compare Novavax and J&J directly? Because there's a difference between looking, Novavax's top line data reports mild, moderate, and severe, and then the top line we saw for J&J was moderate and severe. And so when we're talking about the original strain, the vaccine efficacy against the original strain for Novavax, that's 96%. With mild, moderate, severe. If you're looking at just moderate and severe, that's 94%. So there's not much of a difference there. But just to address that question.
There's not. And vaccines generally are better at preventing mild disease. But J&J makes an interesting argument. They have lower neutralizing titers, and they make a case that their vaccine is the best of all the vaccines at generating a T-cell response. So instead of relying so much on antibodies to prevent the infection of cells, they're saying what they do is stimulate what are called cytotoxic T lymphocytes. So think of them like white blood cells that roam about looking for infected cells to kill, right? So killer T cells to go and find the infected cells, which means that they're basically saying, we know that our vaccine is more likely to let the virus breach our initial defenses, the antibody defenses. You maybe will get some mild COVID, but our T cells are going to keep it from progressing to severe. So they make this nuanced argument that when you see a very similar impact on mild, moderate, and severe disease, in that you don't prevent as much mild, but you're also similarly effective at preventing moderate and severe, that's an indicator that you're working via T cells. Whereas the humoral folks, they're better at preventing the initial infection, but once the initial infection kicks in, then, it could progress to severe disease, which isn't really true though, because simply by slowing the infection, you're allowing your body to naturally develop T cells and still prevent that infection from becoming severe. So there's a lot of complicated arguments that are starting to emerge by the different companies, but they're really so speculative right now. Like, we just don't have enough data to know why these vaccines are, showing us different kinds of performance characteristics. So a lot of speculation, a lot of hypotheses, but we don't feel like we can really say we know what's true.
Definitely. And the questions keep coming in. Another one I thought that would be relevant is, what are your thoughts on where the other protein subunit vaccines currently stand in their role in getting us out of the pandemic, including Sanofi or Clover?
Maybe you guys can comment on that. I've had my my head in one place for a while now.
Great, happy to. So we have had an update from Sanofi. I think it feels like a year ago now, but I'm sure it was just actually last month, where they updated us and told us that based on the formulation of the vaccine, their subunit vaccine that they took into their phase 1 trial, although the immune response in young adults was on par with recovered patients, so convalescent sera, they actually saw a suboptimal response in older adults, in the elderly. So they're going back and reformulating. They think it's a problem with the antigen and the actual concentration they have with their original vaccine. They think the antigen is less than they had thought previously. So they're going back, reformulating, starting a phase 2B in February. And basically the bottom line is that while it was previously projected that Sanofi would be online mid this year or second half of this year, they're not going to come online until at year end now, fourth quarter. And that is important because I think a large part of getting us out of this pandemic will be just having that supply, that manufacturing for 2021. And Sanofi is definitely a global vaccine player, and they will have the capacity to provide billions. I think they projected around 1 billion, I think, for 2021, now pushed back to 2022.
Okay. We need all those companies with their conventional vaccines to come online, right? And I think we're going to learn also a lot more about different adjuvants. Novavax controls its own special Matrix M adjuvant, which is kind of similar. It comes from the same tree as bark, I believe, as GSK's AS01. But I think that's the one that Sanofi and GSK were collaborating on that ended up being worse. And, I don't know if I would say that means AS01's no good. I suspect that there's a problem with the antigen that Sanofi had, because I think AS01 is a pretty good adjuvant in the case of Shingrix. It's a very effective vaccine to prevent shingles. But we're going to see like Clover and Dynavax collaborating on a different adjuvant, right? So we're going to ultimately find out, how to make the best of the conventional vaccines, and they're going to have a chance to prove themselves on these new strains, right? I do think it's going to be harder though to develop a totally new vaccine where you haven't seen protection, because you're going to have all these first generation vaccines. So I wonder, have you heard anything about when we're going to switch over to simply being able to get your vaccine approved based on neutralizing titers?
So there were comments from, Dr. Fauci and other, not necessarily from the FDA, this past couple of days at a conference. And the current thought is definitely you're not going to need a full-blown phase 3 efficacy trial for these new strains. You're not going to need to enroll that 30K, 40K large trial. It seems more likely that you'll need a phase 1 and then a phase 2A perhaps, just showing that immune response in that broader population, and then immunobridge to correlative protection. So a certain level of antibody we know to be predictive. And there's no set timeline on when we're going to switch over to that yet. That's still definitely in open conversations with regulators. But I could imagine, at least when we're near mid-year of this year, or second half mid-year in particular, we'll get more guidance on that. because these next gen vaccines, particularly the one from Moderna that's targeting the new strains, and also Novavax, they're set to enter the clinic, first quarter and second quarter of this year. So definitely, I think we'll get more clarity on the path forward by mid-year of this year.
Okay, well, we're going to be keeping track, I think, of bivalent vaccines and new South African strain antigens. There's a cool idea out there, by the way, that you don't have to, maybe you shouldn't wait to see how a new strain, like what new strains emerge. What if you grew virus in a laboratory in the presence of neutralizing antibodies that were generated by the other vaccines? So as soon as you can vaccinate some people with vaccine against the original strain and the South African strain, take their antibodies and now put in a petri dish and start growing virus in the presence of those antibodies and see what mutations emerge that allow that virus to circumvent that immunity, right? And then take that freak laboratory virus, sequence it, take its spike protein as an antigen, vaccinate, some animals, primates, use their antibodies now to select for more virus, and see how weird the virus gets as it's under more and more selection pressure. And as you discover what are the virus's tricks, what mutations might it come up with at some point in the future when it's exposed to this evolving immunity, maybe you put that as a third antigen preemptively into your vaccine. And so try to give people a very different set of antibodies, that basically anticipates possible routes of resistance. So that's an interesting idea. It'll be cool to see whether anybody actually does it. But that presupposes that there's a narrow set of tricks that the virus has. It could be that this third antigen you've come up with in a laboratory is merely one of, 50 different ways that the virus could, mutate away. And so you've merely closed off one of 50 new doors, but that's an awful lot of effort to have gone through, and the virus just, picks up new mutations that send it off in the direction of the other 49 doors. So what people would love to get is a universal vaccine, some kind of vaccine that shows the immune system the virus's truly sensitive spots that it can't change. If it tries to change them, it falls apart, it can't infect cells anymore. So, what are called conserved epitopes. And really try to drive our immune systems to generate antibodies against those spots, and now be able to nip every version of this virus in the bud. But I think we heard Fauci say, either Fauci or somebody else say, yeah, I don't think that universal vaccines are even possible for this strain. So I don't have enough data to go on, but I defer to others that are closer. If they say that it's not possible, then that's probably the safer base case assumption. All right.
Yeah,
what else?
I think that would be like a good way to get ahead of the virus, but I feel like you would have to be very careful about making strains that are resistant to the antibodies in a lab, just because.
Oh, they're already doing it. So people are already evolving these things. I actually did that in grad school with HIV.
Okay.
So, the cool thing about HIV, we discovered was the mutations that let the virus learn new tricks in a laboratory actually left the virus incredibly sensitive, susceptible to being neutralized by the immune system. And so, there's a trade-off between being able to pick up a new trick that lets you infect cells more easily or whatever, and remaining shielded against the immune system. So it may be that this virus does have only a finite number of tricks it can exploit before its machinery basically stops functioning. So it really comes down to how many doors do we have to close off. And I do think that those lab experiments, you can do them in a BL3 or 4 facility to keep it safe, are going to be useful to shed light on that.
Mm-hmm. Yeah, on a slightly related note, I guess we could get an update from Shan or you, Peter, on the live attenuated vaccines and kind of the role that we think it might play at some point.
Yeah, Shan, what do you think?
Yeah, I can take that. So I guess I'll take it together. Live attenuated and inactivated vaccines. These are the whole vaccine candidates. We have more updates from the inactivated vaccines, mostly from China and Russia. So Sputnik 5 is the one from Russia. Sinovac is the one from China. And those, I would actually say just there's less data out there. So for instance, for Sinovac, there's 4 different top line point estimates out there from different global sites. So we're ranging anywhere between 50 to 90% efficacy, depending on the site of the trial and the location. But bottom line, I would say that these vaccines currently, especially when you look at their phase 1 immunogenicity, don't appear to be as good as the mRNA or Novavax protein-based vaccines, more similar to the adenovirus vaccines, just top line. And we continue to accumulate data there, although when we're talking about manufacturing and supply, these ex-US, Chinese, Russian vaccines are more likely to supply their domestic markets and their geographies when we're looking at these supply deals. So, and then just sort of to Peter's point earlier, the benefit, and one thing we hedged about against like earlier on is for the whole vaccine, you just present the body, whole virus vaccine, you present the body a lot more epitopes to make antibodies against, so a lot more shots at making something that's neutralizing or that would prevent severe disease. So in the case that spike wouldn't be good enough, although now we know that spike is definitely good enough. And then Mike, I think we had
what else?
The last topic.
But yeah, I mean, we're getting lots of questions surrounding the Vaxart data. So maybe just generally, someone's asking what our view is on nasal vaccines and the role of IgA mucosal antibodies versus IgG. So yeah, maybe we can start to tackle that with the last 5 to 10 minutes we have left.
I know you guys looked at that earlier today, so why don't you take a crack at that?
I can start with that too. So yeah, we had top line data from Vaxart's phase 1 study today. And the bottom line is that, they did show an immune response when they looked at the production of IgA, so mucosal antibodies in your nasal passage from nasal swabs. And they also saw killer T cells, so cytotoxic T cells against the spike protein. What they didn't see were these systemic neutralizing antibodies that all of the other vaccine candidates have shown, so neuts against the spike protein in your sera. And the biggest thing here is, now we know that systemic neutralizing antibodies against the spike protein work. They're protective. That has limited read-through now to Vaxart's data because they do not show these systemic neutralizing antibodies. So the question here is, does having these mucosal antibodies in your nasal passages, is that enough to really prevent transmission of the disease and severe disease when you're lacking this other sort of key read-through data piece that we've accumulated from all of these other vaccine candidates? So that's sort of one reason for the activity behind the news that we've seen today. And just personally, I think so I don't know if I mentioned this, I should have, they're an oral vaccine. And personally, I think oral vaccines have a lot of potential really to solve some of the logistical challenges around worldwide, vaccine distribution. But there's a reason where, to solve that problem, there are a lot of challenges up front that I would say when you're adding on to this pandemic situation are difficult to sort of solve in that timely fashion compared to some of the more tried and true platforms that we know work and have sort of more infrastructure to distribute.
Yeah, I guess one could imagine, first dose with one of these, RNA or protein-based vaccine, and then boosters down the line with an oral vaccine, which is easier to distribute and has, different distribution advantages. And I guess that brings up another question that's been brought up that we may have touched on in the past, but we could address is mix and matching different modalities. So maybe having a protein base for your first vaccine, and then RNA for a second.
So I think it's a great idea when especially you consider that we can't seem to keep track of who got what first dose. And then later we're going to go to boosters. you know, and people are like, wait, what'd you get the first time? You know, my medical records don't speak anymore. You switched insurance, it's gone. I mean, America's in a pretty sad state. I got to imagine it's pretty hard elsewhere around the world. So you're going to see mixed and matched, you know, vaccinations, and I think it'll be fine. I think it actually makes a lot of sense. You know, you think about, you know, the adenoviral vaccines, they probably make a perfectly good initial dose, right? You know, J&J had great data, really, when you think about it, you know, for ending the pandemic. You know, it definitely gets the job done. And you could imagine, you know, following up on a J&J first dose with, you know, one of the other vaccines as a second dose, right? Especially since it's not a great idea to redose adenoviral vaccines for the reasons we talked about. And so I think we should make the most of our adenoviral vaccines. Whether or not it makes sense to keep juggling that modality for the long run when you've got plenty of, you know, extra, when you will eventually have plenty of extra doses of, you know, either mRNA or protein adjuvanted vaccines, that I don't know. But if they're right that their vaccine, that adenoviruses do a particularly good job at generating T-cell immunity, and that somehow that is special and useful and, you know, worth having around, then you would want to try to work in adenoviral vaccines into the overall vaccination schedule, right? The trouble is we don't know enough about T-cell immunity to know that, you know, that J&J is giving us something that we really need. I think other groups would probably say like, yeah, it's quite plausible that, you know, they do a better job at T cells, but then they would also say, but we don't know whether whatever levels of T cells they generate are meaningful, right? And that's true. Like, we just don't. We know that antibodies carry the day for most if not all vaccines, right? They are the primary means for preventing infection. We know that antibodies are necessary. We know that antibodies are sufficient. There are some cases where you can prevent an infection simply by transferring antibodies from one person to another, right? That's what human convalescent sera is. So that's been shown to work. There's a drug called Synagis, which is just a pure monoclonal antibody that's given to preemies that prevents RSV. There's no T cells, nothing like that. Like, antibodies alone work. You know, what we don't have any evidence of is that a pure T cell vaccine works, right? So we don't know whether T cells are necessary for anything, but all else being equal, it's nice to have them. So it'll be cool to see whether they end up doing some mix and match trials and maybe compare something like a trial where you randomize people to either get a shot of J&J or a shot of, let's say, mRNA or the Novavax vaccine, followed by a shot of like mRNA or the Novavax vaccine, right? So basically just randomize them to using adenovirus instead of a conventional vaccine as their first shot. And if it turns out that those people do better, that, you know, get that mixed and matched vaccine, then that's cool. I think there are approved vaccines. Is it for Ebola, where there's actually a vaccine that's a shot of, I think, some adenovirus followed by some vaccinia virus as the second shot. So two different viruses, kind of like Sputnik mixes two different adenoviruses. So it's rare to see mixed and matched vaccine protocols, but I hope we see more of those. All right, we got 1 more minute. What's the coolest question we can tackle? It's overwhelming number of questions. I answered a few of them, just a handful here. Let's see. I don't know. I'm cooked. I think maybe we call it done here, and we'll go through some of these questions and see if it's good material for the next session. Thank you, everybody, for joining. And I hope that you guys get your vaccines soon, that they become available to you, and that you say yes. It's definitely a good idea. Nothing of what we said should discourage anybody from getting any of these vaccines when they become available. But keep your eye on, you know, the emergence of boosters and upgraded vaccines, and watch how technology lets us stay ahead of this virus. I'm pretty sure that it can, and that it will. And definitely wear a mask in crowded places now and even after you get vaccinated. By the way, if your doctor, and I heard one doctor say this, if your doctor says, "Oh, I got vaccinated, so I don't have to wear a mask," get a new doctor, right? What these data show is that you can be vaccinated and you can still end up being a carrier of the virus. And so I hope that people, who engage with any unvaccinated people, whether they've recovered from a prior infection or not, continue to wear masks in order to shield those people from whatever strains may be circulating. All right, enough on that. Till next time.
See you, everyone.
Thank you.
Thanks.
Thanks, guys.